Good morning, everyone. Today we are starting with chapter 11, which looks at public health enemy number 2 and growing poor diet and physical inactivity. By the end of this lecture, you will understand why poor diet is now ranked among the leading actual causes of death and what public health is doing and struggling to do about it. Let's begin by looking at the key terms we will be using throughout this chapter. Here are the terms you will need to know going forward. Number one, body mass index or BMI, calorie labeling, dietary guidelines for Americans, NHANES, which stand for the National Health and Nutrition Examination Survey, and is our main data source of this chapter. Obesity and overweight as distinct categories. Waist to hip ratio. And two policy terms, sin tax and sugar sweetened beverages tax. Keep these in mind. We will define each in context as we go. Let's set the stage with a bit of evolutionary context. Introduction. Evolutionary mismatch. For most of human history, getting enough food is required real physical effort. Hunting, gathering, farming. It's only in the last 100 years or so that large and growing share of the population has had constant access to more food than they need, combined with almost no requirement to be physical active to get it. That mismatch between our evolutionary biology and our modern environment is the root of the problem we are discussing today. Sorry. The result, people are getting heavier, and this is genuinely unhealthy trend. So much so that poor diet and physical inactivity are now ranked among the top two behavioral causes of death in the most countries and in the United States of America especially. So, why exactly does this matter for health? Let's look at the disease connection. Why weight matters. Multiple studies have linked excess weight to cardiovascular disease, diabetes, most type of cancer, and a range of other conditions. Because of this well-established relationship, reducing the prevalence of overweight and obesity has become a central goal of public health practice, not just a matter of appearance or personal preference, but genuine population health priority. Now, let's put some numbers on the scale of the problem in the United States today. Look at this figure. This is amazing figure. In 2015 to 2016, 71.3% of the United States adults were classified as overweight. Within the group, 39.8 were obese and 7.7% were severely obese. To make that concrete, for a woman of average height, 162, severe obesity means weighing at least 105 kilogram. For a man of average height, 175 centimeter, it's at least 122 kilogram. So we are not talking about a small subgroup. We are talking about the majority of Americans adult falling outside a healthy weight range. Given how common this is, you would expect a lot of people to be actively trying to lose weight, and they are. Weight loss attempts. Losing weight appears to be even harder than quitting smoking, even among people who are highly motivated. National Health and Nutrition Examination Survey, the data from 2013 to 2016 shows that 56% of women and 42% of men reported trying to lose weight. But, and this is important, most of them are unsuccessful. This lead this lead us to something the author, the researcher, calls a genuine paradox. The dieting paradox. The Institute of Medicine, IOM, out something almost contradictory. Obesity keeps rising in the United States, even though more people are dieting than ever before. Americans spend more than 33 billion US dollar annually on weight loss products and services, diet foods, artificial sweeteners, diet books, fitness club memberships, weight loss programs, and yet, as a population, we keep gaining weight. This tells us something important. Individual effort alone is not solving this problem. So, why is that? Because obesity itself is not a simple condition. So, obesity is complex. While it's easy to measure the association between obesity and disease risk, that doesn't mean the relationship is simple cause and effect. Obesity is shaped by genetics, individual behaviors, and social and environmental factors. And here is a subtlety worth remembering. A person's disease risk can be affected independently by their diet and activity level, regardless of whether they are technically overweight or not. So, Healthy behaviors matter even for people who are not overweight. Now, we understand the complexity. Let's get precise about how obesity is actually measured in public health, starting with the body mass index. Obesity is not an extent in the eye of the beholder, often the beholder looking in the mirror. But public health needs a more objective measure, and that is body mass index. Body mass index is calculated by dividing weight in kilogram by height in meter square. Let's look at the table in the next. This table. This table lets you look up to body mass index directly in centimeter and weight in kilogram. It covers body mass index value from 19 to 35 and heights from 147 to 191, which covers most of adult population. This is a practical, clinical, and teaching tool. I would encourage you to actually find your own approximate body mass index on this table. I mean approximate. If you need precise your body mass index, go to the equation. Weight in kilogram divide by height in meter square. Now, what do these body mass index numbers actually mean in terms of official categories? Most research shows that weight related health risks begins to appear around body mass index of 25 and rise more sleepily past 30. The National Institute of Health and CDC have agreed on standard category. Overweight body mass index from 25 to 29.9. Obesity body mass index over 30 or 30 and more and above. And severe obesity body mass index 40 and higher. These are the categories you will see used throughout the rest of the chapter and in most public health literature. With those categories defined, let's look at how many Americans actually fall into each one, broken down by sex. Using the National Health and Education Examination Survey data from 2013 and 2016, for adult and older, 74.6% of men and 67.4% of women were overweight or obese. Interestingly, when you isolate obesity specifically, the patterns flips slightly. 36.8% of men were obese compared to 40.7% of women. So men have higher overweight or obese rates overall, but women have higher obesity rate specifically. That's a subtle but important distinction. These are not just numbers frozen in time. They represent a decades long upward trend. Let's look at the trend data for men first. Figure 1. The percent overweight in males in the United States. This figure tracks the percentage of overweight males in the United States across six survey 1.12345 six survey. The period from 1960 to 1962, all all the way to 2013 to 2016, broken down by age group. Notice the clear upward shift across every single age band over time. Also, notice the shape within each survey period. Overweight prevalence rises through early and middle adulthood peaks because there is the bottom is the age. So increase rise through early and middle of adulthood peaks somewhere in the 45 to 64 years, the range, and then decline a bit in the 75 and more. Now, let's compare that with the same trend but for women. The figure 2, percentage of overweight in female. The pattern of women follows the same general upward trajectory over time, and the same rises, then decline shape by age. Historically, women's overweight rates started somewhat lower than men's in the 1960s, but the gap has narrowed considerably by the most recent survey periods. This is consistent with what we just saw in the aggregate national health and the nutrition examination survey numbers. Let's now step back from the gender, from sex, and look at how overweight prevalence change across the lifespan. As you see in figure 1 and figure 2, overweight prevalence rises with the age through most of adulthood, but then actually decline in the 75 years and older. This might affect a combination of factors: survivorship bias, since heavier individual may have higher mortality before reaching that age group, as well as natural changes in body composition and appetite in older age. Now, let's turn to another major demographic factor: socioeconomic status. There is a strong educational gradient here. College graduates of both sexes tend to be thinner than those with fewer years of education. This effect is specifically or especially pronounced among women. Those with less than 12 years of education are nearly twice as likely to be overweight as female college graduates. Interestingly, this relationship is much less clear cut for men, suggesting that social and economic pressure around body weight may operate differently by gender. So far, we have talked about how much weight people carry. Now, let's talk about something equally important, uh, where on the body that weight is carried. Body fat distribution in the body. There's apples shape versus pear shape. Obesity researcher using simple but useful metaphor. Apple shape versus pear shape body type. Apple shape individual carry fat mainly in the abdomen. This pattern is more common in men and it's associated with meaningfully higher cardiovascular and diabetes risk. Pear shaped individual carry fat in the hip and buttocks, more common on women, and this pattern carries comparatively lower health risk, even at similar overall body weight. How do we actually measure this apple versus pear distinction with the waist to hip ratio? So, waist to hip ratio is calculated by measuring the waist at its smallest point and the hips at their widest point around the buttocks, then dividing waist by hip measurements. The risk thresholds are for men, waist to hip ratio is one signal, elevated risk. If it is more than one, elevated the risk. For women, is not the cutoff point is zero point 0.8. If it is more than this number, so they elevated the risk. And critically, the health risk associated with the high waist to hip ratio are greater than the risk from excess weight alone. This is a good reminder that body mass index alone doesn't tell the whole story. Let's now shift our focus to the population that should concern us most: children. Childhood overweight, growing trend. Childhood overweight has been rising steadily since the 1960s, and this is arguably the most alarming trend in the whole chapter because childhood obesity strongly predicts adult obesity and adult disease. The CDC defines childhood overweight and obesity using body mass index for age curves established before 1980. Overweight is or above 85th percentile, and obesity is above 95th percentile. I will discuss this in details in the nutrition through life cycle course. Let's look at how fast this has actually been rising. Among children and adolescents aged 2 to 19 years, obesity prevalence nearly doubled from under 10% in the 1988 and 1994 National Health and Nutrition Examination Survey to over 17.8% in the 2013 to 2016 survey. That's a massive shift in 1 to 2 generations. Why does the childhood weight matter so much? Because it tends to follow children into adulthood. A study that followed 60 or 679 school children for 16 years found that their weight in childhood was a strongly predictor of whether they would develop cardiovascular disease and diabetes risk factor as adults. In other words, this is not just a childhood problem that resolves itself. It's often a preview of adult chronic disease. One of the clearest example of this is the emergence of type 2 diabetes in children. Type 2 diabetes used to be called adult onset diabetes because it was believed to occur almost exclusively in adults. That's no longer true. Obese children are now increasingly being diagnosed with it. It's especially likely to be diagnosed in American Indian adolescents who have high prevalence of obesity, though Black and Hispanic children are also affected at elevated rates. The health consequences of childhood obesity go well beyond diabetes. Let's look at the full scope, the complication of childhood obesity. Childhood obesity affects virtually every organ system: cardiovascular, respiratory, kidneys, gastrointestinal, and musculoskeletal. And the evidence suggests that the longer someone has been obese, the worse the effect. So, children who become obese early face a longer cumulative exposure. One particularly striking statistics: obese adolescent girls are 2 to 3 times more likely to die by middle age compared to girls on normal weight. The consequences are not only physical, there is a significant psychological dimension too. Obesity in children is associated with depression and anxiety, social isolation, and low self esteem. Children who are worried about their weight may adopt diet that harm both their physical and psychological health, and they are at increased risk of eating disorder like anorexia and bulimia. There are also longer term social consequences because children are less likely to complete college and more likely to live in poverty as adult. Now that we have covered the epidemiology of obesity across age, across race, and socio-economic lines, let's let's pivot to one of its two root causes: the diet. Diet and nutrition. Obesity results from the combination of unhealthy eating patterns and insufficient physical activity. But in this part, I will talk about just for diet. And in the next part of the same chapter, I will talk about the physical activity. But it's worth emphasizing each of these factors independently affect health, regardless of whether a person is overweight. We will look at diet in this section and physical activity a bit later in this chapter. So, what exactly is wrong with a typical American diet? More obesity analyses find that Americans eat too much protein and fat and too few fruits and vegetables. These patterns drive high cholesterol and high blood pressure, both major cardiovascular risk factors. The evidence connection or the evidence connecting diet to cancer is somewhat less clear cut, but epidemiologic studies do show higher breast and colon cancer risk in populations eating diet high in meat and low in produce. Diet is also a major driver of type 2 diabetes. And there is a less obvious one: inadequate calcium intake among young women tied to low dairy consumption is expected to drive rising rates of osteoporosis later in life. Given these risks, how does the federal government try to guide Americans toward healthier eating? Since 1980, the USDA and WHS have jointly reviewed and released the dietary guidelines for Americans every 5 years. This process is often continuous because the food industry tends to resist any recommendations calling for eating less of particular substances. Despite that pushback, the 2015 to 2020 guidelines are clear. Emphasize the fruits, vegetables, whole grains, and fat free or low fat dairy. Include lean meats, poultry, fish, beans, eggs, and nuts, and reduce the saturated fat. The trans fat also reduce it, reduce salt and added sugar. These guidelines are illustrated with a very recognizable visual tools. Let's look at it. In the figure 3, this is the choose my plate graphics, which replace the older food pyramids model. It uses a place setting image to make the guidelines intuitive. Half of the plate should be fruit and vegetables, and at least half of the grain you should eat by whole grain. The choose my plate dot gov website also lets individual build a personalized profile with a calorie target based on their activity level plus recommended food plan. Now, how well are Americans actually following these guidelines? Not very well, unfortunately. USDA dietary survey show that while the American diet has improved somewhat over recent decades, most people still fall well short of these federal recommendations. About 75% of the population eat too little in the way of vegetables and vegetables, fruits, dairy, and healthy oils, and too much in added sugar, saturated fats, and sodium. Of all of these categories, vegetables are the most commonly omitted food groups entirely. One particular category of food deserves special attention here because of how strongly it's tied to obesity trend, sugar sweetened beverages. Sugar sweetened beverages or WSP and obesity. Sugar sweetened beverages, look at this photo. The consumption has been a major driver of rising obesity, especially in children. The proportion of calories the average American got from soft drinks and fruit drinks more than doubled between 1977 and 2001. More recent in the National Health and Nutrition Examination data, survey data, 2009 to 2016 shows that the average American consumes about 154 calories per day from sugar sweetened beverages, roughly about 7% of the total calorie. That's actually an important to improve. There's improvement from 2003 to 2004 when the average was 205 calories per day. But among 2011 to 2014 data shows that 63% drank sugar sweetened beverages on any given day, while sugary drinks consumption has been rising. Something else has been quietly declining: the milk. Look at the photo. Milk. Milk consumption has fallen 38% overall, including among children aged 2 years to 18 years. Precisely the group for whole milk consumption matters most for future bone health. This matters because milk consumption appears to help people control their weight, in addition to providing calcium. Other beverages categories did not change significantly over this period. The researchers behind this data put it plainly: reducing soft drinks and fruit drinks intake would seem to be one of the simplest way to reduce obesity in the United States. Given how clear the data problems are, why have not we simply fixed them? Let's talk about how difficult behavior a change actually is. The promoting healthy eating behavior is hard to change. Eating habits developed over an entire lifetime and are shaped by family, ethnicity, media, and the broader social environment. They are not simply a matter of individual willpower, and we know changing them is extremely difficult, even among highly motivated people with a direct medical reasons to change. Consider diet adherence in patients with diabetes across three separate studies. Adherence rates range from 20 to 73%. Among dialysis patients following a prescribed renal diet, adherence was only 39 to 42% in the two studies, and only 30% of people with high cholesterol successfully stuck to low cholesterol diet. The barriers to healthy eating. Fresh fruits and vegetables are relatively expensive and often simply unavailable in poor neighborhood. Fast food, by contrast, is inexpensive and heavily concentrated in low income areas. On top of that, United States agriculture policy subsidizes industrial commodity crops that produce high calorie processed ingredient rather than more nutritious produce. And food advertising, this is the problem. Food advertising overwhelmingly promotes processed foods because they are simply more more attractive for the industry to sell. Given all these barriers, what does the research say about our long term prospects for reversing obesity through these approaches? The Institute of Medicine, IOM, conducted through evaluation of weight management programs and reached a fairly sobering conclusion. Despite billions of dollars spent, few people achieve a healthy weight, and even fewer maintain that weight loss beyond 2 or 3 years. As a result, the Institute of Medicine recommends reframing our thinking entirely toward lifelong weight management rather than one time fix, and encouraging even modest goals like simply avoiding further weight gain. Importantly, they, they note that even small weight losses can meaningfully improve self esteem and health outcomes for people with obesity related to chronic conditions. Given the limits of individual level approaches, public health has increasingly looked to policy. Let's examine the tobacco control playbook. being applied to the food. Public health advocates argue that tackling obesity will require the same kind of multi pronged strategy that worked against tobacco. Community based efforts to boost access to healthy food, changes to national agriculture policy to make nutritious food more affordable, and regulation of food industry advertising to enforce ethical marketing standards. Alongside educational campaigns like 5-day proposed policy tools include mandatory calorie, fat, and sugar labeling, a prohibition on misleading health claims, and requirements for fast food restaurants to post nutritional information. One of these proposals has actually been implemented. Let's look at the calories labeling law. In May 2018, a provision of Affordable Care Act went into effect requiring restaurants chains with at least 20 locations to post calorie counts on their menus. This includes things you might not expect, like popcorn at movie theater chains and drinks at bar chains. The evidence on how effective this actually is in changing behavior is still fairly limited, and more research is needed. It also worth nothing the political dimension here. Now, let's shift to one of the most actively debated policy tools in this space, taxing sugary sweetened beverages. Why single out sugary drinks especially? Because liquid sugar appears to be worse of, for weight gain than solid sugar. It's less satiating, so it doesn't reduce how much other food people eat afterward. Experimental studies confirm this. People consume more total calories throughout the day when a larger share of those calories comes in liquid form. And researchers uh, uh, when the researcher evaluate the diet drinks for sugar sweetened drinks in youth over 12 to 18 months, participants lose about 3 pounds on average, about 1.5 kilogram. There is also strong diabetes connection because sugar in drinks is absorbed into the bloodstream faster than sugar in solid foods. Sugary drinks are particularly effective at promoting diabetes. Let's quantify these risks more precisely. The number here are striking. Each additional daily serving of sugar sweetened beverages associated with 13% increase in the risk of developing type 2 diabetes and 17% increase in the risk of coronary heart disease. And critically, these health burdens do not fall evenly across the population. They disproportionately affect lower income households. Let's look at exactly how that income relationship plays out using the next figure. Figure 4, the sweetened sugary beverages. This figure plots daily sugar sweetened beverages consumption measured in calories per person against the household income brackets. You can see a clear downward trend line. Household earning under 15,000 US dollar consume around 210 calorie per day from sugary drinks, while household earning 75,000 US dollar or more consume about 110 calorie per day, roughly half as much. This strong negative relationship between the income and sweetened beverages consumption is central to the policy debate we are about to discuss. Because of this income pattern, taxing sugary drinks raises a real equity question. Let's frame the debate. SSB or sugary sweetened beverages tax function as what is called a sin tax, similar in structure to cigarette and alcohol taxes. It raises the price of a products that harmful with the goal of discouraging consumption. The justification for taxing goes beyond the individual harm too, because these products drive up healthcare costs that get started across society uh, through a program like Medicare or Medicaid. There is a public, not just private, cost to excess consumption. Let's shift now specifically to youth obesity, which deserves its own closer look. Youth obesity, the youngest children. Perhaps the most alarming part of the childhood obesity trend is that even every young children age 2 to 5 are fully caught up in it. Obesity in this age group rose from already concerning about 10% in 2007 to 2008 to 13.9% by 2015 to 2016. This is a group we might assume is too young to be affected by broader dietary and lifestyle trends. But clearly, that is not the case. One major challenge in addressing childhood obesity is that parents often don't recognize it when it's happening. Let's look at that. Parental perception gaps. In a follow up to 1988 to 1994 in Nutrition Health and National Health and Nutrition Examination Survey, after children were actually weighed and measured, mothers were asked to classify their child's weight. Nearly one third of mothers of overweight children aged 2 to 11 said their child was about the right weight. And things got worse over time. not better. In 2007 to 2010, the same survey among parents of overweight, not even obese, just overweight, 8 to 15 years old, only 21% correctly identified their child's weight category. It's not just parents who misjudge this. Children misjudge their own weight too. Children's self perception. In 2005 to 2012, National Health and Nutrition Examination Survey asked the children from 8 to 15 years old directly about their own weight. Among overweight boys, 81% said they thought they were about the right weight. Among overweight, 71% said the same. This tells us that awareness itself is a real barrier to addressing this problem. You can't address a problem you don't recognize you have. Given this awareness gap, some states have turned to schools as a way to close it. School body mass index assessment. About half of the United States now have laws requiring school to assess students' body mass index, often with requirements to report results back to the parents. This is meant to address exactly the awareness gap we just discussed. But it's controversial. Critics worry about the potential for stigma, psychological harm from labeling children by weight category in school settings. It's clear that any effective effort here has to involve parents directly, not just schools. Given these concerns, what guidance have professional pediatrics organization actually issued? The American Academy of Pediatrics guidelines in 2015 issued updated obesity prevention guidelines for both pediatricians and parents. The recommendations are fairly practical. Limit sugary sweetened beverages, high calorie snacks and sweet. Make healthier food options readily visible and accessible. For example, keeping fruits on the kitchen counter instead of hidden in a drawer, and actively encourage children to eat fruits and vegetables. Let's now look at a more comprehensive systems level report in childhood obesity from the Institute of Medicine. In 2005, the Institute of Medicine published Preventing Childhood Obesity, Health in the Balance, explicitly calling childhood obesity a critical public health threat. The report calls for contraindicated or sorry, the reports calls for coordinated actions at the federal, states, and local level, and specifically recommends given the Federal Trade Commission real authority and resources to monitor food advertising directed at children. Why does that matter so much? Because the report found that more than 50% of television advertisement targeted at children promote foods high in calories and fats and low in fiber and nutrient density. Think candy, fast food, snacks food, soft drinks, and sugary cereals. The report also has specific recommendations about the school environment, which has become battleground of sorts. The IOM report recommends that governments establish nutritional standard for all food and beverages sold or served in schools. But in recent years, we have seen the opposite trend in many places. Food and beverages companies have expanded their presence in school through vending machines selling unhealthy snacks and drinks, fast food options in cafeterias, and educational materials that are really just vehicles for fast food and junk food advertising. Let's bring it all together with a conclusion. To summarize the dietary half of this chapter, poor diet and physical activity, or I want to conclude just the poor diet because this is in part one, is ranked among the top behavioral causes of death in the United States. Americans eat too much protein and fat and not enough fruit and vegetables, a pattern that unhealthy independent of its effect on body weight. Rising sugary sweetened beverages consumption and declining milk consumption have both fueled an obesity epidemic, specifically in children. Current dietary guidelines call for more vegetables, fruits, whole grain, and low fat dairy. And sugar sweetened beverages, taxation is emerging as one of the more promising policy tools for addressing this at the population level. That concludes the chapter 11, part 1. See you in the next part of the same chapter. Goodbye.